Okay, so thanks very much. I'm going to talk a little bit about why partnering patients is important. So I've veered a little bit from just the research-only topic. So I'm going to talk to you a little bit about some of the clinical organization that we've done and how patient advocacy as well as patient and family advisors have been so important in our work. And then also to talk about ways in which the patient voice can be quantified to incorporate that in research. So how can we take the patient's voice, some of the discussions we're having here today, and ensure that it's put in a form that can then be received by the research community such that it can be integrated. And that can be done in any way then. It could be in a clinical trial, it could be in a policy statement, it could be in a health services delivery or population health. Really, once you quantify it, it can be integrated in any way. So why is partnering with patients important? So at least in cancer care, it's pretty clear now that we're getting to a point where there needs to be a system transformation. And I think in most of the developed world, as well as in the developing world, as the cancer systems sort of move forward and get a point of maturity, we're realizing that potentially the way that we've been doing things before really wasn't probably the most efficient. So this movement really started, and when you talk about really even patient advocacy, although it was existent before, it really started, at least in North America, in the early 2000s, where this IOM, the Institute of Medicine report came out, which talked about what exactly our cancer system should look like. What's an efficient healthcare system? And these are the 6 aims for improvement: safe, effective, patient-centered, timely, efficient, and equitable. Now, what does that really mean? Like, what does patient-centered really mean? So this was a report that came out from Patricia Gans, who talked about what's a high-quality cancer system. So what would be the components, the 10 components of a cancer system that works well, that's cost-effective, and that produces results? And the number one thing that she described was a system that revolves around the patients. And this is kind of what we're all talking about today. We're talking about how do we change the system such that the system, the research, et cetera, is revolved around the patients rather than vice versa. We've had a lot of discussions about that today, about how that might look like. So what she described was a system in which patients were at the center, in which patient-clinician interaction supported that, and we talked about that a bit this morning already in terms of, we talked about communication and how that might look like. A workforce that is engaged to meet patients' needs, and then evidence. So evidence to inform clinical care, which would be the research part of things, for example. And again, we want the research to be patient-focused. We want research that makes sense and that will lead to different patient outcomes. So that can even be basic science, right? But we want basic science research that's going to lead towards changes, kind of like Simone's question. This research is great, but where do we see the steps going? We need to have a pathway moving forward. And then to do this, we need to have quality measurement, and we need to performance improvement and measurement models that sort of include the patient's voice, include the patient's experience, and understands from a patient's point of view, how is the system working? Okay, and our payment models should be attached to that. So if for chance the system is not working, we want to change the action follows dollars. That's the reality of things, and regardless of what system you're, a single payer or a private system, action's going to follow the dollar. So if the dollars are reallocated or realigned into ways that are patient-centric, the change in the system is going to occur. So I just want to point out there's been a number of problems that have been pointed out in the United States about gaps between clinicians and between patients that I think need to be identified. These are American examples, but I certainly don't think that this is by any means restricted to the United States. So these were studies that were done in different areas. These were mostly in comprehensive cancer centers in the States. These aren't neuroendocrine specific, but these are just cancer. So, when you think about this was a study done, 10 years ago, not even, where a little bit over half the patients even really understood their diagnosis. And I can imagine if we think about neuroendocrine cancers, the number is probably actually lower than this, right? This is including all breast cancer, prostate cancers. So when you think of neuroendocrine cancers, that gap, and the number of physicians who believe their patient knew was over 3/4. I still wonder, I actually emailed the authors of the study, never got an answer. What about the other 23%? What were they thinking? Like, they were just okay with it? But again, it just sort of displays the gap. This is one of the most alarming studies that I quote all the time. This is patients who had metastatic non-small cell lung cancer. So this is stage 4 lung cancer, again, not neuroendocrine patients, but this is before the era of immunotherapy. when the average survival for this group of patients was probably around 6 months. And these were actively people getting chemotherapy within the NCCN centers in the United States. So these are national cancer centers in the United States, comprehensive cancer centers. Almost over 2/3, almost 3/4 of patients getting chemotherapy with all the toxic side effects, with all the implications to their life, to their families, to their well-being, thought the reason they were getting chemotherapy was to get rid of all their cancer. And 1/3 thought that they were getting their therapy for cure. So to me, this is alarming. So the idea of informed consent is really thrown out the window when we have 1/3 of patients who are getting treatment with a toxic agent who don't necessarily understand why they're getting it, who are simply getting it because they were told to get it, or have different goals in mind. So there's no way to define success in this scenario. If the person getting the therapy here thinks, I'm going to be cured of this cancer, no matter how effective that treatment is at elongating the person's life, they're going to view this as a failure, and they're not going to be getting it's not going to match the patient's goals and wants. So this is why this sort of care is so important. So what we've tried to do in Ontario is really move towards what we call person-centered care. And we use the term person-centered care because we want people to be identified as people before just identifying them only as patients. And we're probably somewhere along here. So where we all started from is here. It was care organized for the system and those who work for it. So this is when a neuroendocrine patient would get 4 different appointments, one with the surgeon, one with the medical oncologist, one with the nuclear medicine, one with the endocrinologist at 4 different times, at 4 different intervals. Maybe had to get 2 CT scans in between because they weren't organized, and each one was organized in their own CT scan, and had to get blood work done 3 times, and had to take off 7 days of work, and had to arrange childcare, and had to leave their pets at home, which is something I never thought of before, and had to, really reorganize, uphold their whole life for months at a time just to get their investigations done. Then we moved to a system where care incorporates the patient's needs, but it's still doing it to the patients. And I think this is probably where we're at right now, rather than now a system where we're trying to move with, where care is organized with patients and their families to meet their needs and wants. Now, when I present this sort of stuff to clinicians or even to healthcare providers or anybody in the healthcare system, they'll often tell me, well, we come to work every day for this reason. We want to meet the patient's needs and wants. We come with that good intention. I think that's very much true. I think almost everybody that works in the cancer system, you don't choose oncology as a career unless you're really interested in improving patients' lives, in being involved, and trying to make the healthcare of people a better thing. But unfortunately, it doesn't always work that way. So I'm going to share with you some of the ways that we can ensure that our goals are aligned. And I'm speaking now from a clinician point of view. How do we ensure our goals are aligned? So one thing, now this is the clinical side of things I want to show you, and I'll talk about research in a second, is improving NETS care in Ontario. So we have a single-payer cancer system, or healthcare system in Canada, where we don't have a private component. There are some gaps in care, such as pharmacare, et cetera, which hopefully we're improving on. But our service delivery is all public. You're not allowed to pay for services. It's all run by the cancer organization called Cancer Care Ontario, that in Ontario would organize cancer for about 14 million people. So we're the largest province in Canada. We have about 91 new cancer cases this year, and Cancer Care Ontario manages all of that. Okay. The ways we do that is we do it through 13 regional cancer programs. Geography-wise, you can see how massive we are. Ontario is probably the size, about 3 times the size of Germany. And so we have 14 different regions with 13 different cancer centers that we've divided up to help provide cancer care to the region and provide patients care close to home. But as you can imagine, this is a massive undertaking to coordinate a cancer system accordingly. And then to try to fit NETS and neuroendocrine cancer within here is even more. So, over the years, we didn't really have a NET cancer center at all. About 10 years ago, we started at Sunnybrook when I started on, and we started very slowly. We asked our administrators for some time to devote to neuroendocrine cancers, and they basically laughed us out of the office, saying that was a ridiculous idea. It was their exact words, that there was just 5 patients a year. What are you going to do? Well, there's certainly more than 5 patients. We saw 350 new patients last year alone. And they gave us Friday afternoon as the time period, finally, after our bugging, because no one wanted clinic space on a Friday afternoon. Now we have full-day clinics every Friday and every Tuesday, and we run 5 rooms every Friday. We're one of the biggest clinics in the hospital. But it kind of shows the attitude that we face, not only as trying to challenge the disease, but challenge with administration to try to get attention to something like this. So what happened was we had a lot of advocacy done from our patient group, from the CommNETS group in Canada, which has been great, and it actually initiated through the pressure between a joint collaboration between clinicians saying we need to start paying more attention to neuroendocrine cancer in the province, and from the patient advocacy group, including CommNETS, to say we need to spend more attention. We actually formed a neuroendocrine advisory committee that we started over the last year. Now, Cancer Care Ontario has a very active improvement in terms of we want to organize care, but we also want to make sure that the quality of care is what we want it to be, and we have to manage cost. Because as a single payer system, this is all being paid out of taxpayers' money. We don't have private reimbursement. So Cancer Care Ontario has a big mandate to fill. And one of the ways we've done this is through a very active role of patient and family advisor engagement. So besides NETS, I spend 1 day a week at Cancer Care Ontario. I run a program there called Person-Centered Care, which was a brand new program involving how can we incorporate the patient's voice into system transformation. And this is just for the whole cancer system, not just for neuroendocrine cancer. And we now have a patient family advisory council in every region of the province. We have about 200 patient and family advisors that are constantly embedded in the work we do, right from the point of inception, right to the point of results, looking at the quality metrics, making sure these quality metrics are meaningful to patients, that they make sense, and that they are translatable to system action. So we formed this Neuroendocrine Advisory Committee, and it's chaired by myself and Dr. Lita Forbes, who is the head of all medical oncology of the province. So we've co-chaired this. And what's been unique about this is we've actually, for the first time, we now have a larger group of clinicians, administrators, and patients. And we have two streams of patients. We have patients from CommNETS Canada. Jackie Herman is our CommNETS president. She also sits on the committee. But we also have patients who are outside of CommNETS Canada as well. And we actively took that role to make sure that we hear both perspectives. From the advocate point of view, the well-informed patients, the patients that really understand the system and understand the lingo, but also patients who are otherwise outside that system, who might have different experiences in the community that also need to be heard from. So we've all been working together. And these are the goals that we set aligned, including an environmental scan to try to understand what we're doing. Gallium-68, believe it or not, was not available in our province. Out of 14 million people, we had no access to Gallium-68. And I'm proud to say 3 months ago, we finally had this available. Now, what was interesting was working with patients. Patients were very upset. Why don't we have this scan? And understandably, why don't we have this scan? We're the last Western country to potentially have this scan, and really almost around the world, we were one of the largest areas without access to Gallium-68. And part of the reason is that in Canada, we couldn't offer the service because there wasn't a regulated product. So it didn't go through Health Canada regulations, so there wasn't a way to actually offer it. Even if the government was willing to pay for it, which they were, the federal government didn't have a regulated product. And we had to sit down with patients and work through this problem. And I think it really made a difference because then the patient groups also understood what the challenges were. It wasn't a case of just paying for the Gallium-68. It was how do we do it? And we decided to do a registry and had to register it as a clinical trial through Health Canada to collect this data until we have a registered product in the country. But we were able to find a solution. And it was the same thing for PRRT. We now have 4 PRRT centers that we didn't have before. We had to send patients abroad to get PRRT, and we were able, through the same mechanisms, to start moving forward in PRRT. We're now looking at regionalization of care. We're trying to make sure that there is an MCC, an online virtual MCC, given our geography, so that clinicians who want to review the cases or patients who want to be participants in their cases can do it online. And every week we'll have a different region have their MCC that people can log in and listen and hear in a confidential manner, of course. So that everybody in the province, even if you're in a corner of the province, you have access to the same care that you might if you're living in downtown Toronto and can walk over to our clinic. So that's some of the ways that you can see we can make phenomenal progress when you bring patients to the table and when patients understand some of the outcomes and how you want to move forward. So as I said, I'll just go over this. We have different patient and family advisors, both in and out of the system. We've been, so far, our successes have been introduction of Gallium-68, PRRT, and now we're on the process of developing this large provincial plan. It looked like how the regionalization will look. Do we need every patient to be seen at a net expertise center? Are there some patients that could be treated close to home? Is there a shared care model we're looking at developing where patients could come to our clinic, be seen, and I could, we could decide together, okay, after some consultation, you need to go on capecitabine temozolomide, but you know what? You can get that in your home hospital, which is 3 hours away. You don't need to come back for every visit to us, and only at the forks in care when it's time to make a treatment decision or the disease has progressed or the symptoms have got worse, that's when you need to come back. So I think, this is an example of how patient advocacy can affect the system, and I wanted to share that with you. So then how about from a research point of view? How do we hear from our patients? So there's patient-reported outcome measures and patient-reported experience measures, and we've talked a bit about them, but they're a bit different, and I think it's important to quantify that as well. So patient-reported experience measures are self-reported experience measures across the continuum of care. And that involves things like everything, like what your radiological test was like. How was that transition? What was the waiting room like? How did you find where you needed to be in the clinic? How were you treated at reception? Things like parking, access to clinic. Did someone answer your phone calls? What was your communication like with your clinician? Were the results explained to you? Did you have time to talk about the things that you wanted to talk about? What was your follow-up? Did you understand the next steps in your care? So it's about the process. Okay, so experience measures are really about the process. PROs, which are getting a lot of attention lately, or patient-reported outcome measures, are the self-reported impact of cancer treatments on a patient's health status or quality of life. So I like to think of these as more clinical outcomes, but they're reported from by the patient. So traditionally, when we think of clinical outcomes as a researcher, we think of overall survival. We think of progression-free survival. But what we don't take into account, or haven't taken into account lately, is things like, how does this treatment make me feel? Does it improve or does it decrease my quality of life? Does it make me feel reaching the goals I want to reach? Or am I feeling crappy all the time on this treatment and therefore my goals are not being met? And from a researcher's point of view, you could say, well, great, you're living 2 months longer. But if you're not enjoying the quality of life you want during that time, and that's going to be different for everybody. Some people are going to have different levels of whether they accept treatments for, then we're not necessarily meeting your goals. So we're not really patient-centered. So even though we may be really concentrated on survival, which is primarily most people's goal, but still, we're not taking into account the patient's voice in that at all. And that's where PROs come into place. So these are two very different measures, but both of them are able to integrate the patient's voice within both. And the reason we do all this is something called the quadruple aim. And this comes from the Institute for Healthcare Improvement. And it's sort of the blueprint, much like you were talking about the iron triangle. It's something similar that is being used. And what we talk about is we talk about population health has to be linked to cost. So population health means, are we achieving the outcomes we want? Are we developing new treatments? Are people living longer? Are we happy? Are the costs manageable? Well, right? We can always do a really great treatment for a very small group of patients with a very high group of cost. But what we want to do is deliver treatment to everybody at a cost that's sustainable to move forward. And then, so you have to include in that then the patient experience. What's the experience of the care? Okay, the outcomes are here, and how we feel is here, but what's the experience in their care? And this has now been changed to quadruple aim, meaning we have to think about things like provider and caregiver burnout. What about the people who are supporting the patients? What are they doing? And we have to be able to look at that. There's certainly a problem with healthcare provider burnout that's happening throughout the cancer system. And it's actually in the United States, it's a tsunami problem ready to happen, because you're talking about 25% of healthcare professionals are feeling burnt out. And if they start to pull themselves out of the system, we're going to run into some real problems. So you have to look at this whole aspect. But the patient's voice is very important, both from a patient-reported outcome measure, what's the patient's health from a self-reported basis, and what's that experience in their journey. So when we wanted to look at experience, we wanted to look at it from the province-wide level. This is all cancers, and we wanted to look at it to see if we could measure it. We found that there was actually no good real-time measurement tool for patient experience that could be done across the province. So I'm not going to go into this, but we did a very large project where we developed our own thing called Your Voice Matters. It's a 23-item survey, and then we rolled it out of all the 14 cancer centers in 4 phases of iteration. And basically, when a patient comes in, every patient that comes into the cancer center completes both a patient-reported outcome and a patient-reported experience measure. They're offered it at every visit. And they're able to then give their data. The patient-reported experience measure is confidential. It doesn't go to the clinician at this point, but the patient-reported outcome measure does. So the clinician can see that you've reported a 9 out of 10 out of nausea, a 7 out of 10 of fatigue, and therefore when the clinician sees you in your appointment, they're able to look right away and say, nausea is an issue today, how are we going to address that? So you're able to meet the patient's needs a bit better. So this is just some of the reports of the experience measures that we have. This is from last year. It's translated itself, interestingly, so I can't. But you can see here, like percent positive response for wait time after check-in. Only about 2/3. That means about 1/3 of our patients were really unhappy and they had a high amount of anxiety or unpleasant time while they were waiting for their time after they were checked in. So we're obviously, this is an ongoing problem. Discuss worrying concerns. We hover around the 80 to 90%. These numbers here are actually different. This is actually months, sorry, as the time went on. But you could see here that we ran about slightly below 90%, which means about 10% of our patients left our cancer center not feeling that their worries or concerns were met. That's huge, right? We're seeing 91,000 new cases a year. That means 9,000 people with new related cancers left our cancer center feeling that they didn't get what they needed. So when we brought them together, we actually did some research and found that these things actually correlated. And we were able to, when we do it through research, we're able to do a conjunct analysis. We're able to see that they group together. And then with patients, we named these to produce what's called a composite indicator. So we only have to report one of them, but we're able to collect the data on all. So my needs, were you treated with respect? Did you have enough time spent were things explained well? My concerns, did someone discuss your symptoms with you? Were your worries and concerns discussed? Were you involved in decisions to the extent that you wanted? Were you allowed to be asked questions? Were your friends and family involved to the extent you wanted? And then what's interesting is this third one is called My Interactions. And these were named by patients. We had patient groups come, focus groups, and name these. And again, this just gives an example of how sometimes patients can think very differently than the administration. And the administration may have good intentions, but really you can't see things through the patient's shoes. And this is why stuff like this is very important. My Interactions counts as things like easy to find, wait time at arrival, the reception was polite, wait time is clean and comfortable, the exam room. This is really about your physical environment. And I think from the administration point of view, if you had said My Interactions, they would have thought more like interactions with your healthcare provider. But really, patients identified this in our focus groups as interactions with the physical environment was as important for them. Like, could they get to the clinic? Could they find the directions? We have a massive cancer center at our center, for example. So again, these were patient priorities that were sort of club-classified. And the data proved that this actually made sense. This was common among all our cancer patients. And then now we publicly report these by cancer centers. So we have quarterly reports where we report them, where you can see for My Needs, which again was about treated with respect, spend time explaining things well. These are the numbers we're getting. We're still hovering. Some cancer centers are doing better than others. And this is a quality improvement data now. The cancer center can say, this is actual data from patients, quantified with research that validated, that can say, this cancer center 12 has a lot of work to do, right? So if I'm the RVP or the regional vice president, we call them the head of the cancer centers, I know that I'm going to get dinged for this, and my funding is going to be attached to this. So I better get this number improved. I better figure out what's going on in my cancer center. I think I'm doing a great job, but obviously we're not. There's room for improvement. And what kind of quality improvement can I do to bring these numbers up more along the lines of the provincial average? Same thing for My Concerns. You can see the numbers here, as well as for My Interactions. So this is sort of a way that you can take the patient's voice and put it. This now is the largest real-time patient experience data set in the world. We have about 100,000 data points right now. The potential for this is exponential, because you can take this data now, we can link it to healthcare records. So we've already started to produce data that say, for example, women have a better experience than men in our cancer centers. Younger patients have a poor experience. Patients from the age of 20 to 40, I think we talked about adolescents today, have a much poorer experience, probably because their expectations are very different, right? Maybe they want different needs, so are we meeting those needs? We know that patients that come from high areas of high immigration have a poor experience because maybe the translation services aren't there or because their needs aren't being met. But this also provides an opportunity for us to individualize the care to the patients around us. And this is, all publishable research that this is about understanding the patient's voice and translating it. I'm going to just go quickly through this because I know we're getting short of time, but we do the same thing with patient-reported outcome measures. We've been doing it for a long time. We collect something called the mitten symptom assessment score, and this is, again, about symptom prevalence. And you can see here that out of our patients in the province, about 70% reporting fatigue, so we sort of know where to spend our resources and how to make sure our patient-reported experience patient-reported outcomes are being met. And one of the reasons it's helpful from a cost perspective is if we collect this data, we can align the system in such a way where we're spending the dollars where we want to be, where we're making sure people's lives are being improved. So we actually know that people who have really high scores on their well-being, they have a higher, statistically significantly higher rate of ending up in the emerge within 7 to 14 days. We can predict what patients are going to end up needing to come in for acute care in the emerge because their needs aren't being met, because we're able to collect these scores. And then by collecting them, we can act on them early. And it's a win-win situation. No patient wants to sit in the emerge. No patient wants to come in on Saturday at 2 in the morning, nauseated or vomiting, for example, and having to wait 3 hours, if they're lucky, in the emergency room to see an emerge physician who doesn't know their case, have to explain everything all over again, see a non-cancer professional. No oncologist wants their patient to get the report on Monday morning saying your patient was in emerge overnight, and get their boss looking at them saying, why are your patients always ending up in emerge? What are you doing? And the hospital, it's an expensive endeavor for the hospital to have patients in emerge. Going to emerge is a no-win for anybody. And if we can avoid that by listening to patients early and having a systematic way of improving, we're not only improving costs, but we're improving patient outcomes. It's a win-win situation. So this is kind of where we want to get to in Ontario. We're not there yet, but we want to have some sort of a report like this, which would be individualized for patients, explaining their outcomes, explaining their experience, and have a trend over time so that when you see all of a sudden nausea has gone from a 6 to a 9, right away as a clinician, I can address that. So when I see this report, the first thing I can do and say, pain is an issue today, let's hit that. Rather than me starting from the scratch again, right away we can spend the time that we have, which is sometimes limited, but we can spend it in an efficient way. So how does this involve neuroendocrine cancer? So right now we have a lot of studies that include, all the trials now are including quality of life or health-related quality of life. This is good, don't get me wrong, but these are very generic tools. And they obviously do not often have as much relevance in neuroendocrine cancer as potentially they might in other cancers. These are mandated by funding agencies. Everybody includes these in their trials now, but the reason is because we want to be able to put a cost to how much we're improving quality of life. But we really want to also know about how is this efficient for our neuroendocrine patients, because neuroendocrine patients are not the same as every other cancer patient. They have special needs and they have a different trajectory of disease, as we heard this morning. So there is one tool, the URTC GI-NET 21 questionnaire, which is used. It's been criticized because really so far no study has it been shown to be meaningful, i.e. the treatment has shown it to be improved or changed. So it really probably isn't reflective of patient voices. So there's been a new project that we've been working with Dr. Sella at Northwestern, and some of you may have already been involved in this. I think some of the groups here have been involved. It's to look at new patient-reported outcomes that are driven by patients, that the outcomes and the voices of patients are being driven in this. So we want to look at the highest priority symptoms and concerns for patient diagnosed with pancreatic, GI, and pulmonary NETs. Okay, so these are actual trying to understand what is the right patient-reported outcome that we can collect that actually has impact from a neuroendocrine point of view, not a generic tool. And it's been a long process. It's still only halfway through. There were some clinician interviews about what symptoms are important. There were patient interviews, and I believe that some of the organizations here were part of that. So thank you very much for that. And then the correlation. And I actually got permission to share some of the early data with you back on this project, if you haven't seen it yet. So we did clinical interviews. These had to have people who were physicians or nurse practitioners with 3+ years of experience treating at least 100 patients with NETs. So they sort of understood NETs. And they were asked about, what's your experience? What do you think the disease symptoms that are important to collect are? And what are the side effects of treatment that you think are important? And then patient interviews were done. And these were, again, looking at the same questions of physical disease symptoms and the treatment-related side effects. So what were the side effects of the treatments? And what were the symptoms that the disease made you feel that are important to you and affect your life and are meaningful for you? So I'm going to go right into results just for sake of time. So this was the expert priority list. So when we looked at the GI-NET for non-functioning GI-NETs, you could see here, fatigue, abdominal pain, weight loss, nausea were some of the big characteristics. When you ask the patients, some of them overlap, but some of them didn't. Diarrhea, vomiting, cramping was a big area. And when you look here, this sort of correlates the two. There were some that there was agree were priority symptoms, diarrhea, vomiting, abdominal pain. Patients brought up issues like cramping and abdominal pain. 63% of the patients in their interviews brought this up. No clinicians brought this up. Gas and burping, 38% of patients brought this up. No clinicians brought this up. I think this is a really interesting example where this is meaningful to a patient. This affects their life. This affects them going out. This affects them, their social interactions. This affects how comfortable they may feel at a dinner party. A clinician doesn't think about these things, right? A clinician is thinking about what we're taught in medical school, diarrhea, vomiting, all good things. Not that they're good things, sorry, but all good things to think about. But seriously, we're missing big points. Some of the stuff the experts had, weight loss, jaundice. So, weight loss was a huge issue for clinicians. And I understand why. As a clinician, when I see weight loss, I think something's going on with the disease. I'm not necessarily thinking, how does this impact the patient? Weight loss, to me, triggers a red flag in my head saying something is going on here. I need to do a CT scan quick, or I need to do something else. But from a patient point of view, things like gas and burping may have more of a social impact. When we look at pancreatic NETs, I'm going to go skip right to this here. So again, some things are very common, diarrhea, abdominal pain, nausea. But again, look at patient priority symptoms. Bloating, 36% of patients brought up bloating as a priority symptom. No clinicians. Night sweats, 27% of patients brought up night sweats. They can't sleep at night. Maybe they inconvenience their partner. They have to change their sheets. It's a nuisance. Physicians or clinicians didn't really think of it as a priority symptom. And again, priority symptoms, look at weight loss. 90% of clinician or healthcare providers thought of that as a priority symptom. Only 10% of patients, jaundice, right? And again, the reason is because these are more clinical symptoms. Important, but do we need to be collecting this in this way? No, we should really be asking about things like gas and flatulence. 46% of patients brought this up as a priority symptom. Again, 0% of clinicians. So this is why it's so important to go to the patients and collect this information so you can collect a meaningful endpoint that really truly is patient-centered rather than just the assumption, even with good intentions, that what we're doing is patient-centered. Lung nets, I'll go through this quickly as well. Shortness of breath, fatigue, cough was agreed upon. Chest pain was a big difference, 43 to 0. Diarrhea and flushing, people still had it. We traditionally don't think of diarrhea and flushing in lung nets, and that's probably why it was 0 here. But here you could see that in fact it still was an issue. And again, you see common things like abdominal pain. For lung nets, most people, abdominal pain wasn't an issue for them. For clinicians, they still thought of it as an issue at 43%. A big discordance between what clinicians would think and what they would think. And finally, I'll go through with carcinoid syndrome. Food sensitivity, a big one for patients. 56% of patients, almost their number one priority was patients with carcinoid syndrome. How do they manage their foods? What kind of foods are going to set them off? That is a huge impact on their life. The clinicians didn't really quite realize that, even though I think they probably knew it. They just weren't able, not being in their shoes, they weren't able to have that experience of being at a dinner where all of a sudden the food set you off and you had to deal with it in a very acute situation. Again, gas and flatulence and nausea were predominantly more patient-centered that maybe the clinicians didn't get. So, the other thing was look at terminology. So I just wanted to also mention, in this project, we've really been very clear to talk about the different terminology. I think this gets along the lines of what we're talking about today, about the 13-year-old reading level. When we say diarrhea, what do we mean by that? When we say nausea, what do we mean by that? I've had patients come back to me and say, I ask them, are you nauseous? And they say, what is nausea really? And it's really hard term to explain. Try to yourself, try to explain nausea to yourself. It's quite a difficult term to explain. So you need to have words that can relate to people and that can potentially be meaningful. And you need to be able to understand that in a way where when you're asking the questions, you might say to somebody, do you have chills? But someone may not think of night sweats as chills. But from a clinician point of view, you're in the habit of doing these things. So this is why these sorts of validated tools are important. And hopefully, the next step out of this now is the validation stage to look at potentially at a few centers. We're going to collect this information from patients, again, in a prospective manner. And then this could be the tool moving forward in clinical trials to say, is the new drug treatment actually meaningful to patients in terms of improving their quality of life? Not a generic tool that really never changes. It neither improves nor decreases. But really, do our treatments, they should be improving our patients' quality of life, not just survival. So this is an example of where partnering with patients in research is so important. And then the last thing I want to share with you is a way to change how we hear the patient's voice and incorporate that into research and decision making. So one of the things we've been doing through the CommNETS organization is trying to understand treatment preferences. So one of the unique things about neuroendocrine cancer is we have treatments, but we don't know the sequences. partly because we don't have the patient volume that breast cancer or lung cancer might, partly because neuroendocrine cancers are very different, right? We were talking last night at dinner that if a patient with breast cancer comes through the door, of course there's individual differences, but predominantly, I don't treat breast cancer, but I can tell you what the first line treatment, second line treatment, third line treatment would be. With neuroendocrine cancer, you don't see algorithms very often, or at least well-done algorithms, because it's very difficult. There's so many individual factors. Are they functional or not? What's the Ki-67? What's the differentiation? Are they secreting hormones or not? What's the patient's goals and priorities about? How much is symptom control an issue? How much is PFS an issue? So we really have to involve patients in their decision making. Sometimes that can be difficult because patients can get overwhelmed with information. We talked a bit this morning about how sometimes the timing is not the right point in the consultation room in your 15-minute consultation to say, what would you like, PRT or everolimus? What's the person going to say to that? They're going to have to really understand the evidence and everything else behind it. And there's no easy way to sort of involve patients in that decision effectively, but we know we need to do it and we should do it. So this is something called a discrete choice experiment. And so what we're trying to do here is produce multiple situations in which you have to choose between multiple treatment profiles. And we talk about the side effects, how they're given, the potential for tumor control. So things like what are the rates of mouth sores? What's the rate of nausea? What is the rate of constipation? How is it given? How many visits do you have to make? How much time is it going to take? What are the outcomes that we would expect? And try to balance them against each other. And this is what I would truly call involving patients in their care, as well as trying to quantify the patient's voice in a meaningful research methodology. So this is kind of what it would look like. So it's called a discrete choice experiment, and they're quantitative methods for eliciting preferences and the relative contribution of the variable underlying those preferences. So when I first saw this, I got an example. It was from New Zealand, where it talked about what city would you want to live in. And the factors that they included were things like weather, congestion, traffic, transit, sports teams, restaurants and culture. And if I asked everybody in this room, we would all have different choices. Some people would say, I want to live in New York, and I don't care about the smell and the garbage and the congestion. The restaurants are amazing. The city has a vibe that I love. And some people say, I want to be as far away from that as possible. I want to live in a rural area on an acreage of land where I have horses, where I have my own peace, where I don't see anybody for days, and that would be their ideal lifestyle. And we're all very different. And some people would balance it, right? Some people would say, sunny, I don't care how busy the city is, I want the sun to be out every day. Some people would say, I'm happy to live in a city where it rains all the time, but I want to make sure my transit system is good. I don't want to waste time going to and fro work. And how do you balance those things? So this is, it would ask questions about, like, would you rather live in a city where the temperature is 30 degrees, but you wait 2 hours for transit, or where you're raining every day, but the transit is efficient? And it's a series of questions, and it sort of quantifies it for you in a way. It helps balance these judgments, and you keep getting these questions until it comes to a point where you've understood. So we're trying to put this in terms of neuroendocrine cancers, and sorry, my contacts are squinting this, so I can't necessarily read them out, but this one, it says chance of having severe fatigue or tiredness that interferes with your daily activities, a 5% chance versus a 2% chance. But on whole of that, you also get no chance of having low blood count that increases your risk of infections. Here, although you have a less chance of fatigue, you have a 13% chance of risk of infections because of low blood counts. So you would answer this, and they would just keep giving you a series of questions until it sort of helped understand what those patients may be. And this could be done on an individual level to help people sort of understand the differences, but it could also be done on a population level. If we're trying to choose between treatments, like should we put patients on PRT or everolimus? Some people may not like the idea, for example, of having to come in to hospital 4 times. Some people like the independence of taking a pill at home. Some people like the idea from PRT of saying, I come in, I do it, and I'm done. And that's it. It's a time-limited thing, whereas everolimus is indefinite. Patients ask me, how long do I need to be on this treatment? We don't know, as long as it works, right? And you can tolerate the side effects. So some people may prefer that, and it really depends on the person, on the population. So our objective is to understand which treatment attributes are most important to NET patients when choosing between different treatments. And then we also want to look at the clinicians or caregivers to see if their preferences are different than what the patients would choose. We want to understand, are there attributable profiles that match real-world treatment for NETs? Do these translate to each other? And we want to understand, are there subgroups of patients who have different preferences? Do young patients have different preferences than older patients? Do patients who live farther away from a cancer center have different preferences than patients who live close to a cancer center? So what are those differences? Do people from different socioeconomic statuses have different ratios? Maybe somebody who is really struggling to meet ends meet every month does not want a treatment that's going to keep them away from work. They would rather have a treatment that keeps them, allowing them to work, provide stability to their family, versus some people who have maybe resources and means want to be fully immersed in the treatment and get the most effective treatment in the shortest time possible. And those would all reflect on different characteristics of patients. So we've developed 2 scenarios. We tried to develop 3. It was very difficult because of the way that it sort of turned out. So we've now done it down to 2. And these, we based the data from clinical trials. We took all the information from what was published on clinical trials. And so far, we've had these 2 scenarios. The first line is pancreatic neuroendocrine tumors after somatostatin analogs. So after people have progressed on somatostatin analogs, what should be our appropriate treatment option? We don't know really. Is it sunitinib? Is it everolimus? Is it capecitabine and temozolomide? Is it PRRT? And so we've gone through, what's the average length of time before it begins to grow again, i.e. that's progression-free survival. How is the treatment given? Is it a pill? Is it an injection? How often they need to be in? Chance of having mouth or lip sore, for example, because some of the target agents not being able to eat or drink can be a very significant side effect. Chance of having some of the different side effects that we would go through. And so it sort of lists them all out. Our second scenario is, again, small bowel neuroendocrine tumors after progression of somatostatin analogs. And again, the choice is between PRT, everolimus, and escalation of somatostatin analogs. So some people may prefer, they like their somatostatin analogs, they may want to escalate them and see if that works for them because it gives them more independence. Some people would want to go right to PRT given the evidence from the NETTER-1 trial. And so it tries to balance against that. And so the demographics we're collecting have been really from the patients have been age, gender, location of residence, and their distance from their cancer centers, their employment status. We're trying to keep it as anonymous as possible. From the clinicians and caregivers, they're just going to be asked about their country and their place of residence in case there's different attitudes. We know, like, we've already done some of this work in Australia, for example. The clinicians recommend PRT much more than they potentially would in North America. And that's partly due to availability. They've had availability longer. So those sorts of things. And then from the disease point of view, if some diseases, functional status may make a difference. If you're very symptomatic, if you have carcinoid syndrome, you may choose different treatments based on that. So far we've just had, now we've had 10 people. We did 2 raises of 5. We did some focus groups. We really have to make sure that these terms are understandable, that they meet health literacy endpoints, that they're relatable, that they have some validity. So far we've done a couple of them, and you can see here the results have been varied as we go along between the different patients, reflecting the heterogeneity of people, that they're going to have different priorities. And so we're getting ready to launch. The second pilot's going forward now. If anybody's interested, there's a website's already set up. It's not collecting the data yet, but it's set up, and if anybody wants to give any input or any thought of it, I'm happy to share that with you. We would certainly welcome your thoughts or your input into the survey before it goes forward. We've put in ethics applications across the CommNETS countries, and we're going to start the recruitment soon. It's going to be open to anybody, so if your organization thinks this might be something you're interested in, we'd be happy to provide you. It's just a link on a website that you would go through, and it's about a 10-minute survey that would go forward. And then we'd be happy to present back the results. But I think this is the way that research can be driven by patients' voice. So it's not only including patients in clinical trials and design, which is important, but I wanted to share with you that actually quantifying the patient's voice and putting it into terms that the research world understands and recognizes can make it possible that all research sort of takes this into account, and then it really makes it natural that the whole system would be aligned to patient-centered care. And being a new dad, I felt I just had to share that. That's my new son, who's a month old now. Yeah. Thanks. No, I'm enjoying it.
Yeah, he's enjoying it, but he might be in trouble when he gets home, I think. So I think thank you, Simron. Always so exciting, and I've always loved that last study. I remember first seeing that at a CommNETS meeting, and I'm so glad it's off the ground and would be really excited to be involved. I think there's a question over there.
Thanks so much for that presentation. Hello. It's not though, is it? Hello, hello, hello. Shall I just shout or something? That's really great, and it's so amazing to see that you're so focused and patient-centric. I suppose what's a slight frustration is how do we... Hello? How can we as a global organisation encourage this sort of attitude towards the importance of patient voice amongst all the clinicians that are looking after NET patients? Because it's so frustrating to see such great work somewhere and then you can see, oh, absolutely none of that is happening somewhere else. And I know that's a very difficult question to answer, but it's quite a frustration because this is the sort of thing that, in my mind, should be sort of obligatory out of the centres of excellence, for example, but it's still only so focused on the science and how many papers you get out. And that's not, I don't think, what we want as advocacy organisations. And I don't think that's what, I mean, patients want both, but it's more a frustration and whether there's, you know, how we can get this across the board, this sort of attitude in your great work that you're doing.
I think I would say, I would say there's probably two ways of looking at it. One is you try to break the current system, this research scientific system that exists where the reality is, at all these centers of excellence, the UNET Centers of Excellence, most of them are university centers, and most of those clinicians are being judged, to be unfortunately honest, not on the care that they provide, or not enough on the care they provide, but they're being judged by the publications they do, by the conferences, and that's how they're being judged by success by their superiors or by the university. So either we break that system altogether and we make care a more important part of judging what makes a good clinician, which I think is important, and we're trying to do in Ontario. But the other part is to be part of that then and to advocate. And I think we were talking about this morning about publishing the results that you have, getting that data like this morning, like we were just talking about that 20% suicide ideation. That's insane. If this was breast cancer and there was a study that said 20% of breast cancer patients have suicide ideation, it would be on the front cover of the New York Times. They would cancel everybody's holidays, all administrators' holidays, and they would call them into a meeting that very evening probably and say, what is going on? We need to solve this problem, and there would be action be taken right away, right? So getting those, I think if you told most clinicians those results, they would be shocked. So I think getting that out there and then supporting this sort of research so that it actually gets there. And once these tools are validated, like if this project about the patient-reported outcomes, if that's validated, then that becomes the standard tool that we use in all clinical trials. Yeah, absolutely.
Got one question here.
One point, and I really loved your presentation because the point of view of the patient is very clear, because what you showed is basically what I live with every single day. The other stuff is really not my priority because I have no control over it. One of the things, I was involved for many years with MD Anderson patient support. And in large institutions like, and it even happens in MD Anderson where they have excellent doctors, I was involved with them for 11 years, patients lie a lot, because they are afraid of their physicians that they're going to be blacklisted because physicians, just like patients, talk. So you have in some cases, and I know several of them, where a patient basically lied about the outcomes of the protocol because he was afraid of getting something worse. So the numbers, the satisfaction numbers were fake. And we get a lot of that. The other thing is we have cases where nurses and physicians call the patients and they say, "Why did you drop me?" And they do some of that in writing. So, but what I really appreciate is the focus of where you're going now. Understanding that there's an error rate in that is extremely important, because a lot of us, and it happened to me many years ago till I took ownership of it, many of us don't really want to become the squeaky wheel, because if we're the squeaky wheel, then the nurse of the doctor might hear something, and then I'm not going to be treated well in that particular practice. So there's a lot of that out there, and it's in support groups. We hear that a lot, but on the outside, you cannot hear it.
And I guess again goes back to, and we do see that even in Australia in some of the support groups. I'm dumbfounded by sometimes the treatment of some of our patients by people that shouldn't do that. And I guess again it goes back to Kathy's point. This is where we need to use our influence as patient organisations to make sure that that doesn't happen, and that changes that the way of that it shouldn't happen, and it puts the power back to the patients. And the choice back to the patients. So I think on that note, thank you again, Simron, and again, thank you for being away from your 1-month-old baby, or you can thank us, I'm not sure. But I will now, we've just made a couple of little changes. So thank you, Tamas. We're going to move Tamas just to after coffee break, his presentation on the added value that patient advocacy groups contribute to patient research. So we'll be coming back here. So we're going to have coffee now, and we'll be back here at 4:15 if we can, or just a tiny little bit after. And then we will wrap up. And we have made a change just to tomorrow, but we will be starting at 9 a.m. tomorrow, just to give us an extra half an hour in the morning as well. And we'll be changing another thing, but I won't inundate you now. Go and have coffee, and then we'll see you back here at about 15:15. Thank you.